Everybody. I understand that there is a large audience in Asia. It's a great pleasure for me to introduce and to talk on this webinar. And my name is Giuseppe Rossano. I'm a consultant cardiologist and professor of cardiology at St. George's Hospital in London. What we will be discussing today is the place of metabolic therapy with trimetazidine in patients with coronary artery disease, and especially the importance of starting as soon as possible the treatment with trimetazidine because of its clear benefits. Now, we know that coronary artery disease imposes a significant burden in patients with angina, because despite the contemporary treatments, coronary artery disease still is a debilitating disease, and often angina and angina equivalents are predictor of future cardiovascular events. We too often tend to focus on angina, but angina equivalents are as important as angina in terms of future events. And for this reason, we need to use adequate antianginal treatment in all patients with angina, regardless of whether they've undergone a revascularization or not. Now, we may have and think that we have different options for the treatment of our patients with ischemic heart disease, but in reality, medical therapy is always the cornerstone of treatment, because if we can have a patient that starts medical therapy and throughout his life, because of the progression of coronary artery disease, of an acute coronary event, development of left ventricular dysfunction, he or she will need to undergo revascularization. But after a revascularization, patients will need to stay on medical therapy anyway. On the other hand, we may have patients that start their journey into their coronary artery disease with a revascularization, say with an initial PCI because of an acute coronary syndrome, but then they will always need medical therapy for their daily management. So I think we don't have to look at medical therapy and revascularization as antithetic, but they should be used adequately in patients whenever is needed. Now, medical therapy is extremely effective in reducing angina. Revascularization, we will discuss that later, for sure is extremely effective in acute coronary syndromes. In chronic ischemic heart disease, much less. Now, we know that there are specific indications for revascularization, either with CABG or with PCI, in patients with chronic stable angina. And these are basically patients with left main stenosis, or patients with 2 or 3 vessel disease and with depressed left ventricular function. The other group of patients is those with a large area of ischemia, more than 10 to 20% of myocardium at risk. But besides these clear-cut indications for revascularization, in the vast majority of patients, medical therapy is warranted. The reason why it's warranted is that intervention has never been able to show any superiority of optimal medical therapy in patients with angina or patients with coronary artery disease. These are the old data from the BARI-2D study performed in diabetic patients with coronary artery disease that clearly showed that medical therapy is as effective as revascularization in predicting survival and event-free survival. So no difference whatsoever in the occurrence of events. And we have to take into account that if we have a procedure that doesn't offer any advantage, then we should carefully assess the risks and benefits of that therapy. And for example, when we have an elective PCI in patients with coronary artery disease, when there is not an acute coronary syndrome, then we see that we have to take into account the risk of stroke, thrombosis, death, myocardial infarction, and all of these are around 7%. But also, what is important, this 21% of patients who get some myocardial injury, as indicated by elevated troponin I levels. And you can clearly see that in these patients, the 1-year survival is significantly reduced. They have a 14% risk of future events. So we need to carefully balance the risks and benefits of intervention. As you can see that the troponin elevation during PCI is associated with an increased risk of death, 2.2-fold, risk of myocardial infarction, 3.2-fold. So significant risks that are not related to the amount of troponin I. Of course, if you have a significant increase of troponin I, this risk is higher compared to whether you have a lower increase in troponin I. So, furthermore, in patients with chronic stable angina, following a PCI, the PCI is not the end of the story, because we see that still there is a sizable proportion of patients, up to 40% of patients, who will develop chest pain after a successful PCI. And just in order to better assess the benefits of intervention, and because interventionalists always claimed that all the comparisons were made between medical therapy and old procedures, like old interventions, then the COURAGE trial was performed in patients with angina and proven coronary artery disease to see whether optimal PCI with a state-of-the-art stenting was superior to optimal medical therapy in improving events. And as you can see, there was no difference whatsoever between PCI plus optimal medical therapy. That meant that all patients who received a PCI also received the full medical therapy compared to optimal medical alone. And this was true at the end of the study, but also after 12 years follow-up. So there's no clear benefit in chronic ischemic heart disease in terms of future events with angioplasty. And even newer therapies like ranolazine failed to confer any benefit in terms of survival or events in patients after a PCI. Now, take this point well in your mind, because we will be discussing the relevance of therapy with trametazidine in these very patients later. Now, but one point is of interest is whether PCI confers any benefit compared to placebo. And for the past 30 plus years, we never had a network comparison of PCI against placebo. The ORBITA trial that was recently published basically randomized patients with proven coronary artery disease that were optimized on full medical therapy to PCI or to a placebo procedure. So basically, the interventionists, they either perform a PCI, or the patients that were sedated did not receive any PCI, but was told that he or she had. And at follow-up, there was a further assessment of angina with exercise test or stress echo. And as you can clearly see, there was no difference between the group who received PCI and the group that received placebo in the number of antianginal drugs at follow-up, especially those patients taking 2 or 3 more drugs, between PCI group and placebo groups. So they were exactly the same. Therefore, the other point that PCI is always useful because it reduces the burden of medications, you can clearly see that it's not true in the first randomized clinical trial. Then the change in exercise time was between patients who received the PCI and placebo. You see, was not different. Was 16 seconds. That was basically meaningless and not statistically significant. And the other point was whether there was any improvement of angina with PCI. And you can clearly see that the number of patients that had class 0 or 1 angina was similar between the PCI group and the placebo group. Possibly there was a slightly greater incidence, occurrence of Canadian class 0, so patients who were asymptomatic in 6 weeks amongst patients receiving a PCI, but this was not statistically significant, and in any case the number of patients with classes 0-1 was similar in the two groups of patients. Now, one important point is that often we tend to send patients to intervention because we believe that there is an increased risk of extensive coronary artery disease. And this was a study that basically looked at whether the clinical estimates of ischemic heart disease is matches the reality in men and women with increased risk of cardiovascular events. And you can clearly see that the real presence of obstructive coronary artery disease is significantly lower of what we tend to expect. This is another reason why we should perform a coronary angiogram only when it's clearly needed, only when it's clearly indicated from exercise test. The other reason why angioplasty is not effective is because in reducing events is because angioplasty basically treats only the lesions that we can see. It does not treat the lesions that we cannot see, that are hidden within the vessel wall, here at IVUS or here with OCT. And also, often you may see that a vessel that shows only minimal narrowing has a significant plaque burden throughout his branch. And you can see that often the plaque burden on the vessel wall is much larger. Therefore, if we treat this stenosis, then we leave a large area that is of a plaque burden that is not covered and is not treated, and that is at increased risk of future events and rupture after a PCI. So I think we also have to revise the concept of critical coronary artery stenosis. As you can see, this was based on the old model that was basically comparing the baseline flow with the hyperemic flow obtained with adenosine, and with the idea that this was the real hyperemic flow. But if you take an athlete, even during strenuous competitions, you see that we never ever have more than 80% of increase in coronary flow. So the real limiting stenosis are those that are greater than 85%. So this is something we should revisit, even looking at more critically at the data of the FAME study with FFR that is widely used. So in brief, the myocardial ischemia, the concept of myocardial ischemia is changing. Of course, we have myocardial ischemia that is related to coronary artery stenosis, but on top of this stenosis, we may have microvascular dysfunction, we may have spasm, we may have endothelial dysfunction that play an important role in determining the presence of angina. And therefore, ischemic heart disease is an angina, in a clinical entity with multiple etiologies that therefore required a more integrated approach. So treatment of coronary vasodilation because of the coronary vessels, the specific treatments of small coronary artery disease, but as you can see, all these diseases, I mean, both the disease of the large vessels and those of the small vessel, lead to an abnormal cardiac metabolism that worsens left ventricular function and worsens angina. And it's for this very reason that we need to target cardiac metabolism, and we need to target our patients with appropriate therapies. Therefore, the old definition of drug of first and second line drugs, it's outdated, and given the new data that came out from large clinical trials like the VASCO, this new proposition has been put forward for the treating patients with a more comprehensive approach. This approach basically sees all the different drugs, all the different antianginals on the same line. Of course, and then connects the different drugs with lines that suggest that they can be used together, but also identifies in red with the red lines some combinations that are not warranted. And you can clearly see that diltiazem and verapamil are not usually the best drug to be used in combination. Also, we have to point out that when we talk about nitrates, we talk only about sublingual nitrates, as chronic nitrates are not indicated in many patients because they may increase the risk of future events. And therefore, we have to take into account the importance of metabolic therapy. And in order to give you an idea how important is the optimization of cardiac metabolism, we have to think that the heart beats more than 100 times per day, that pumping more than 10 tons of blood every day, and requires 6 kilograms of ATP per day. So a very significant amount of energy. This is obtained converting the free fatty acids and glucose into energy for the actin-myosin interactions. So the substrates that are used from the heart are the free fatty acids and glucose and amino acids through the beta oxidation and the entry into the Krebs cycle. But also there's the production of energy through the oxidative phosphorylation of ADP in the mitochondria to high energy ATP that is then transferred to the myofibrils by creatinine kinase. Now, in order to understand what is the importance of cardiac metabolism and glucose metabolism, we have to just look at what happens at cardiac metabolism during stress. You see that at rest, we have glucose is used only produces only 40% of the energy through the carbohydrate oxidation, and free fatty acids are used to produce 60% of the energy, despite the fact that free fatty acids are less efficient in producing ATP compared to oxygen. Now, the reason for this is that the excess glucose is converted into glycogen, because when the heart requires more energy, you see clearly that there is a shift from free fatty acids into the utilization of glucose before the production of more energy. And trimetazidine is the only drug that really has an effect on cardiac metabolism, because it blocks the beta oxidation and therefore reduces the utilization of free fatty acids, increases the utilization of glucose, and therefore leads to greater production of energy per mole of oxygen. Therefore, when there is a reduction in the availability of oxygen, like during myocardial ischemia, trimetazidine allows a normal functioning of cardiac cells. The fact that this effect is true has been shown in humans that were taking with ischemic heart disease, that clearly showed a very significant reduction in the phosphocreatinine ATP ratio compared to healthy subjects, and the use of trimetazidine normalized this energy production. But a very important finding was the fact that trimetazidine is very effective in reducing acutely myocardial ischemia during PCI. This study was performed during the pre-stent era when the long inflation balloons were used. And as you can see, patients receiving trimetazidine in red had a longer time to ischemia after the balloon inflation and shorter time to the recovery of the ischemia after the balloon had been released. These data were mirrored by similar effects on chest pain. Now, this tells you that it is important to have trimetazidine on board even before having a PCI, also because other studies that followed showed that patients who received trimetazidine during a PCI had a significantly less troponin I release compared to those who were not receiving trimetazidine. This is an important point, and it's because it's also true for patients who have to undergo CABG. And as I showed you earlier, the troponin release during a procedure is associated with future events. Therefore, less release of troponin in patients receiving already trimetazidine is, of course, of prognostic importance. Now, trimetazidine is very effective. It's very effective in patients regardless of the background therapy, in patients on beta blockers plus calcium channel blockers, beta blockers and long-acting nitrates, or on their combination. And as you can see, there is an immediate effect and then a cumulative effect that continues for the next 6 months. So if you see a clinical effect immediately, then you will have to foresee even greater effect in the months to come. What is important is that trimetazidine is very effective in the naive patients, in patients with a short duration of the disease, as it is in patients with longer duration of the disease. And because of the benefits in patients with an acute myocardial infarction, in patients receiving a PCI or having to undergo a CABG, I think that there is a strong rationale for the use of trimetazidine as soon as possible in patients with ischemic heart disease. Now, the supposed benefits of trimetazidine in angioplasty has been also shown by a meta-analysis that clearly showed a 25% reduction of troponin during an ST segment changes or during interventional procedures. Also, recent studies have shown that patients receiving trimetazidine prior an angioplasty or a PCI had a better cumulative angina-free pectoris survival compared to those patients who were not receiving trimetazidine, and this was also associated with a significant reduction of ischemia. So a very good rationale for the use of trimetazidine as soon as possible in patients with ischemic heart disease. This also because, in the CAMILLE study, patients with an acute coronary syndromes who were receiving trimetazidine and had received a primary PCI had a better survival than patients not receiving trimetazidine. So basically, in patients who come to the hospital with an acute myocardial infarction, you see that those receiving trimetazidine did better than those who did not receive trimetazidine. For those patients who have to undergo the coronary procedures, we know that very often, also because they are elderly and have an impaired renal function, there is a problem of kidney injury. And patients who are pre-treated with trimetazidine have a significant reduction of renal disease or renal injury compared to those patients who are not receiving trimetazidine. So this furthermore supports the importance of an early start of trimetazidine in patients with ischemic heart disease. But also, trimetazidine is very effective in patients with also peripheral arterial disease. So we often have patients with ischemic and peripheral arterial disease, and you can clearly see that trimetazidine, in this case, was compared with cardiac rehabilitation, with exercise rehabilitation that per se increases exercise capacity, adds on 30%, 40% on the effect of rehabilitation alone. And so it's very effective in patients, the treatment in patients with peripheral arterial disease. So in conclusion, the management of patients with angina is important and should be pursued using combination therapy, or where trimetazidine has a very central role. Now we can have patients with different background, so with patients with high heart rate, with bradycardia, with hypertension, with left ventricular dysfunction, heart failure, and you can clearly see that here trimetazidine is always a suggested first-line treatment in patients with these cardiac comorbidities, but also we have patients with extra cardiac comorbidities like diabetes, CKD, chronic obstructive pulmonary disease, peripheral arterial disease, and also in all these patients you can see that trimetazidine is always one of the drugs that should be preferentially used. So in conclusion, trimetazidine is a very effective antianginal medication that is also very effective in all the subgroup of patients with different comorbidities, is effective in reducing troponin I release during angioplasty, in improving angina-free survival after angioplasty, and in improving survival of patients that come to the hospital with an acute myocardial infarction. For this reason, I believe that there is a clear-cut indication for its use as soon as possible in patients with ischemic heart disease and angina. So I will stop here, and I will be happy to take your questions.